So, assalamu alaikum, everybody. My name is Ibrahim Alodhaibi. I am a fourth year med student, and today we are going to be discussing psychiatry review questions. So, psychiatry seems pretty easy on the surface and generally is pretty easy. You just need to be able to identify the certain types of disorders that are present, as well as know what to look for in the question because it can be very easily distracting. In neuro, second year, it's not that bad. You just need to know what is what. And throughout this, we're going to be covering that. If someone can just remind me at the end of the session, I put under the notes of the slide a bunch of high yield information from your lectures to just sort of read before you walk into the exam, and we can go over those together. As for the way the style of the questions are going to be, I started off the first half of this lecture with generally longer questions. Those are not like the style of questions you're going to get in your exam, but they provide more information so you can learn how to distinguish the different psychiatric disorders. And then later on in the second half of the lecture, you're going to see the style of the questions that you're going to have in your exam. Without further ado, we'll begin. So I'll read the questions and then I just want you guys to answer me in the chat. So we have a 59-year-old man who comes to the physician because of unexplained weight loss for the past 8 months. During the exam, he's telling the physician that he has been having marital issues with his wife, and he filed for bankruptcy 2 months ago for a business he had owned with his brother until his brother died of skin cancer a year ago. He's tried to hide his financial issues from his wife, and he explains that he's feeling increasingly desperate and no longer sees the light at the end of the tunnel. He worries about finances and what would happen if he developed cancer like his brother and then cannot fall asleep at night. In the morning, he feels tired and finds it hard to start the day. He says that his symptoms began a few months after his brother's death, and then everything started to fall apart. He can't concentrate, and his wife will probably leave him soon. And he lost the business. So what should be the physician's next step? And then here are your options. Okay. How many participants do we have? I'll go for one more answer and then I'll reveal. Or one more person. Okay. Okay. So actually the answer here is C. This is from lecture 1, and this is a very it's very likely you're going to be asked a question like this on your exam. So whenever you're receiving a psychiatric patient whose sort of history is a lot of things that seem to be negative, he lost his business, he lost his brother to cancer, he's having issues with his wife, and he also mentioned that he can't see the light at the end of the tunnel. The very first thing you have to do as a physician in that context is assess the patient's risk for suicide to know whether they're going to be a harm to themselves or not. Evaluation for depression is something that you are going to do at some point. But the very first thing and the very first step you need to do is rule out that the patient is at risk of committing suicide. So is that clear for everybody? Okay, cool. So next question. Ibrahim is a psychiatrist who gets annoyed with his sassy patient. Later on, when he thought about it, he realized the patient reminds him of his younger sister. What defense mechanism am I demonstrating? Of course, Shahid would get it. We talked about this before. Oh, I just revealed the answer by saying that. Whoops. Maybe she didn't get it. I don't know. Any other answers? Okay. Why not D? All right. Yeah, we can talk about this. That's actually the question that Shahid asked me. So this is countertransference, which is when a doctor is sort of imprinting how they feel about something onto our family member onto a patient. So why not D or why not projection? So first thing you want to distinguish is that when you're talking about like a physician-patient relationship, the terminology you're going to use is transference and countertransference. Also, countertransference and transference is a very specific thing where you're sort of seeing a member of your family or you're seeing somebody in that relationship between physician and patient. Projection, more so, it can be that, but more of the times it's sort of an emotion that you're feeling that you don't want to feel that you're going to put onto other people. if that makes sense. So projection is more so about the emotion, whilst transference and countertransference is more about the actual person, if that makes sense. And then also countertransference and transference is used in the context of physician and patient. So does that make sense, Jude? Okay, perfect. But yes, everybody got it right. Here's a picture for you guys to see it a little more closely. Just know that countertransference is going to be from the therapist or the doctor onto the patient. Transference is from the patient onto the therapist or doctor. It's more likely to be transference rather than for it to be countertransference. That's not really like a high yield thing. It's just something that you can know. That's it. That's the concept. You will, by the way, you will most actually, I can say 100% you will get a question on transference and countertransference. So make sure you know how to distinguish between them. In our neuro final in second year, I think we had 2 or 3 questions about this concept in our final exam. So make sure you understand this. And if you have any questions about it, feel free to ask me. Okay, next question. 45-year-old man is brought to the physician because of difficulty sleeping and poor appetite for the past 4 weeks. During this period, he's also had persistent sadness and difficulty concentrating on tasks, because of which he has been reprimanded at work for poor performance. Over the past 3 years, he has often had such phases with a maximum symptom-free gap of 1 month between each of them. His behavior is causing a strain in his relationship with his wife and children, and his mother died 4 months ago from breast cancer. Physical examination shows no abnormalities, and mental status examination shows a depressed mood and constricted affect. Which of the following is the most likely diagnosis in this patient? Now, I think there's one answer that you're all going to jump at, but I want you to take a second and think about it before putting in your answer. If anyone wants me to go back to the question, let me know. Yeah, I'll show it again. Oops, I showed the answer. I hope you guys didn't see. Let's read the question and I'll explain it to you guys once we get through it. I'm sorry that I couldn't put the questions and the answers on the same page or the same slide. Question scenarios are very long. Any other guesses? I think D as well. Okay. So actually, the answer is A. This is a question that when I gave this lecture last year, a lot of people also struggled with. Um, let's, that's why I said, let's read the question before picking the obvious answer, which would be major depressive disorder. Here's where psych can get tricky is there are certain key words and key phrases in questions where it's going to take you away from one diagnosis to another. Major depressive disorder is one where they do that a lot. So let's look at the key words here that's making this persistent depressive disorder or dysthymia rather than major depressive disorder. So the beginning of the question is pushing you towards major depressive disorder. He has difficulty sleeping, he has poor appetite, it's been 4 weeks, he has persistent sadness. Okay, we're all thinking, sure, this sounds like major depressive disorder. However, we then get key information where he has had this for the past 3 years, and it comes in phases with gaps that are symptom free, which is not something you typically see in major depressive disorder. It would not last, for example, 3 years with gaps that are symptom free, right? And now some people may be thinking, okay, this can be cyclothymia, which is like sort of depression symptoms over 2 years. However, cyclothymia is not going to be as extreme as dysthymia or persistent depressive disorder, because what this patient is having is pretty much all the symptoms of major depressive disorder, but for a much longer period of time, as well as with gaps without symptoms, which is diagnostic more for persistent depressive disorder rather than major depressive disorder. Does that make sense? Okay, great. Now a question like this is less likely to come on your final exam. The reason I put it is because I want you guys to get into the headspace of reading the questions and picking out the key phrases that is going to push you from one answer to another, because that's where psych can get tricky. With that being said, let's go to the next question. So we have a woman who is presenting with the inability to stay asleep, low mood, loss of interest, increased appetite, and constant fatigue. She stated that the symptoms worsened after the birth of her now 4-year-old son, Ibrahim. I don't know why I put my name in all of these. Which of the following is the correct diagnosis? Okay, I'll take two more answers. One more. The kid is 4. You got this wrong with TBL. Oh, this is a TBL question. I think that's where I got it from. Yeah, it's E. Okay, this is major depressive disorder. But can someone tell me why this is not postpartum depression? Exactly. Yes. The symptoms were there beforehand. That's number one. Number two, also, postpartum depression is not going to last this long. Exactly. Postpartum depression typically is going to go away before the child turns 1 year old. But here she said that she's had these symptoms before and she's continuing to have them, even though her son is now 4 years old, which means it's not something to do with the pregnancy and the child anymore. It's something to do with the mother herself. So perfect. Yeah. This is a question that is like, this style of question is very likely to come on your exam. So, yes. Next question. Oh, actually, a Siggy Caps break. Okay. So this, of all of the sort of mnemonics that Dr. Ali has presented to you, this is most likely to be the most important. My recommendation, honestly, is when you get into the exam hall for your neuro exam, you know the little paper that you have with your code and stuff on it. I want you to sit down and write down Siggy Caps and what each thing is, so that whenever you're doing a question that has sort of depression symptoms, you can go through each thing and put a little check next to it to see how many of the depression symptoms they're checking off. All right. Because you need a certain number of these in order to diagnose it with depression, and having it sort of in front of you in words is going to help you recognize, okay, is this person having an issue with sleep? Did they mention that they have low interest in things, etc.? The other one that I would recommend you memorize is Fiesta for anxiety, which we're going to talk about later. Those two, I would say, put them on your little sheet before the exam so that you know exactly what you're looking for when approaching a question scenario. With that being said, next question. A 32-year-old woman is being brought into the emergency room by her husband after claiming she saw wild Pokemon in the street. Upon further history taking, the patient stated that she's been sleeping poorly and hasn't been very interested in her usual activities. Her husband stated that she has been eating less and is not very concentrated in their conversation, and she commonly is hearing voices that others do not hear. He shares that he's worried about her well-being. What is your management of choice? Take two more answers before we discuss this question. Okay, another B. Okay. So I want someone to type in the chat for me. What are we having here? What's going on in this 32-year-old woman? Schizophrenia. Okay. I can see why you would think schizophrenia, but let's again go back to Siggy caps and kind of look at the more keywords we're seeing here. So we have poor sleep, psychotic episode is closer. We're having poor sleep, loss of interest, loss of appetite, loss of concentration, and then also psychotic features like visual and auditory hallucinations. So actually, what we're having here is a case of major depressive disorder with psychotic symptoms. Yes, Shahad, the answer is D. The treatment of choice for major depressive disorder with psychotic features is immediately electroconvulsive therapy. All right. So do people understand sort of why this is not schizophrenia and why it is electroconvulsive therapy and the importance of Siggy caps and all of this? What would schizophrenia present like? We're gonna like as we go throughout the questions, we're gonna talk about schizophrenia more. I don't want to open the whole new topic right now. And then if you're still confused later on, we can discuss schizophrenia as well in detail. But just generally, schizophrenia is gonna have less features of depressive symptoms like in this patient, and it's gonna be more sort of more emphasis on the hallucinations the patient is having. So like tactile hallucinations, feeling of, bugs crawling on skin or something like that, as well as auditory visual hallucinations, thought blocking, and then the positive and negative symptoms also are going to be present in schizophrenia. So, they're going to have loss of certain normal things, but also gain of like hallucinations and sometimes aggression, etc. So schizophrenia, while there are overlaps between sort of the hallucinations that they may be having, schizophrenia is going to present very differently than a patient with depression and psychotic features. So here, the approach to the question and what it should have been is having Siggy caps and thinking, okay, we're ticking a lot of the boxes on the criteria for depression, and she happens to have hallucinations as well, which is why the most likely diagnosis is going to be depression with psychotic features. A lot of the time, the psychotic features that the patients are going to have are auditory hallucinations, which is why I included in this question that the husband states that she is commonly hearing voices that others do not hear. Yeah, that's depression with psychotic features, and the first line treatment is going to be electroconvulsive therapy. Is that clear for everybody? Okay, perfect. With that being said, on to our next question. We have a medical student who just finished their neuroblock last year and has been visiting various doctors over the course of the last 10 months. The student is concerned he has Huntington's disease after learning about it in the block and finding out how terminal it is. He's gone from clinic to clinic requesting genetic testing and imaging of his brain. Just after I didn't even finish reading the question and you guys got it. Okay. Yeah, I think this is a relatively easy question. This is illness anxiety disorder. It's a student who thinks they learned about a disease. They think they have the disease. They're getting tests. Illness anxiety. Everything is coming back normal. Why is it not somatic symptom disorder? Someone could answer that for me. Exactly. He doesn't have any symptoms. Everything is coming back normal. And somatic symptom disorder, he's going to have manifestations of actual symptoms, but they're caused psychiatrically rather than organically. And then there's the explanation for that. And somatic symptom disorder, they're already going to have symptoms. And illness anxiety disorder, you're going to worry about having the sickness, which is what this patient has. And typically, a lot of the patients with illness anxiety disorder are going to sort of latch on to a rarer disease or like cancer or something like that, where if it's unlikely they're going to have something like that, but after reading something or facing someone in the family with something similar, they're going to start believing that they have it. All right, our next question. Linda is a 30-year-old woman who was brought to the emergency room by her neighbors 30 minutes after they had found her unconscious in her yard. They report that Linda has been spending more time at home alone since she recently lost her job. On arrival, she's unable to provide history. Her pulse is 76, her respiratory rate is 13, and her blood pressure is 114/72. Examination shows significant weakness of the left upper and lower extremities. She's able to stand on her toes. Her gait is unsteady, and deep tendon reflexes are 3 plus and symmetric. A CT scan of the head shows abnormalities. Which of the following is the most likely diagnosis? This is a psych question. Yes, I was going to talk about that. It kind of eliminates half of the answers knowing that it's a psych question. But yes, this is a psych question. Actually, it doesn't eliminate half of the answers, it eliminates one. What are we thinking? Okay, D. That's a good guess. I'm gonna wait for one more answer and then we're gonna talk about this question because I can see where the struggle comes from. Yeah, okay. Anyone else want to answer? I'll explain anyway. So actually what this is a case of conversion disorder. And you guys took conversion disorder, I'm correct? Like this is still something that they're teaching. Just to make sure I'm not okay, perfect. So yes, this is conversion disorder, and I believe it was Jude. You asked a really good question of, oh, is this a psych question? Question like this coming in, a lecture of only psych questions, you're gonna be like, okay, so this has to be something psychiatric. But a question like this in your neuro exam, where there are questions about hemorrhagic strokes and etc., that's where you're gonna get confused. So that's another way that psych can get kind of confusing when it's mixed with those things. But let's go over this question and sort of see what the key words are here. So we have a 30-year-old woman. Okay, the age is already something you're not typically going to have like brain bleeds and strokes in someone at 30 years old. They should be healthy. You know what I mean? It's no history of trauma was given, etc. So that's not making you think as much of an organic cause of loss of function. So we have a 30-year-old woman who was found unconscious. And a very key thing that they reported is that she recently lost her job and she's been spending a lot more time at home. And so the loss of a job is a significant thing in someone's life. They're unable to financially support themselves anymore. And a lot of people tend to not want to accept the reality of it. She's unable to give you any history, so we don't know if anything significant has happened to her, but her vitals are normal. All right. She has some neurological symptoms, but when we go and do a CT scan to look for any causes of it, it all comes back normal. All of this is going to push you to say she is having psychiatrically caused neurological deficits due to the circumstances of her life, thus making this conversion disorder. Does that make sense? Okay, perfect. So here's the definition of conversion disorder from your slides. It's sort of broadly defined as neurological symptoms with the absence of any actual neurological diseases. And it happens when there's an acute stress in the life of the person who's having it. So like the example they always give is the wife who caught her husband cheating and then went blind was because she didn't want to see that she was being cheated on. Like that's a common example of conversion disorder. This is just another way that it can happen. Moving on to our next question. These ones are a little more difficult. To be honest, I struggled with these a lot in second year, so we'll take our times with these. But we have a 32-year-old man who came to the emergency department due to abdominal pain, a runny nose, and chills for the last 6 hours. He also has diarrhea and difficulty sleeping. He appears irritable. His temperature is 37.1 degrees. His pulse is 110, and his blood pressure is 140. His examination shows cool, damp skin with piloerection. The pupils are 7 millimeters in diameter and equal in size. Cardiopulmonary exam is showing no abnormalities. His abdomen is tender to palpation. His bowel sounds are hyperactive. He has his deep tendon reflexes are 3 plus bilaterally. Withdrawal from which of the following substances is most likely to cause his symptoms? Any guesses? The addiction drug questions tend to be hard because a lot of drug withdrawals and overdoses present like themselves, but we're going to talk about how to distinguish them. Wouldn't withdraw from any substance. Yeah, that's what I just said. But there are key words here that's going to push you to one answer rather than another answer. All right, and we're going to go over that. Because every withdrawal has a certain feature that's not going to be present in another type of withdrawal. Maybe this is too advanced, but they can ask you stuff like this. I'll guess G. Okay. Good guess. Any other guesses? All right. Yes, the answer is G. So we're actually having a case of heroin withdrawal in this patient. Let's talk about heroin, all right, or opioids and withdrawal of opioids, which is a very common thing that happens, and a lot of people actually do see in the emergency department. All right. So heroin withdrawal, you're gonna have flu-like symptoms, which is kind of present in a lot of withdrawals. You're also gonna have sympathetic hyperactivity, so features of tachycardia, hyperreflexia, all of these are what the patient had. You're going to have GI symptoms like nausea, vomiting, and diarrhea, and this patient had diarrhea. And GI symptoms are important because some withdrawals or overdoses are going to lead to constipation, while some are going to lead to diarrhea. In this case, the patient is having diarrhea, pushing us towards opioid usage, as well as CNS stimulation. So insomnia, irritability, and you're gonna have mydriasis, or like not dilation, when the pupils are wider or bigger. That is another sign of opioid withdrawal. Some of the physical exam findings you're gonna find as well, which are important for opioid withdrawal, is the cool, damp skin and the piloerection. Piloerection, by the way, is like sort of goosebumps when your hairs on your arm stand up. Like that's piloerection. All of those are gonna push you towards thinking, oh, this is a heroin withdrawal, rather than it being like, for example, alcohol, you're going to have the seizures, the delirium tremens, you're going to have more sort of stuff like that. Methamphetamine is going to be more, constricted pupils, constipation, etc. Barbiturates, you're going to have, we'll have a question about barbiturates later. Cannabis, you don't really withdraw from. Phencyclidine is going to have more aggressive things. That's too high for second year level right now. But just know that opioid withdrawal presents like this. Did we get that? Because opioid withdrawal is free game for them to ask you. Not only is it free game for them to ask you opioid withdrawal, it's free game for them to ask you, I don't know why I'm stuttering so much, free game for them to ask you the treatment of it, which is naloxone, methadone, buprenorphine. All of those work as treatments for withdrawal. So take a mental note of that, of this is how opioid withdrawal presents, this is how opioid withdrawal is treated, because they need to, or you may be asked that they can ask you that. Is that clear? I just rambled a lot. I feel like I lost everyone. Okay, sorry. I went on a tangent. Okay, perfect. For our next question, another long one. So we have a 46-year-old woman brought to the emergency department after a bicycle accident, in which she fell on her head and her right shoulder. On arrival, she is awake and alert, and medical history includes type 2 diabetes and panic attacks. I'm going to give you a little hint because this is a hard question. On exam, there is a hematoma in her left temple, blah, 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 blah. This is all irrelevant. Her neurological exam is insignificant. She's given midazolam and fentanyl for a sedation for her surgery. And following the surgery, she remained sedated for a long period of time. And he decided to reverse the sedation pharmacologically by administering naloxone and flumazenil. The patient then has tonic-clonic seizures lasting for a minute. Her pulse is 100, her respirations are 24, and her blood pressure is 145. Pulse oximetry on room air is showing a 98% oxygen saturation. She's drowsy and diaphoretic, and she has a tremor in both hands. Which of the following is the most likely cause of this patient's seizure? This one, I would say, is a very difficult question. I think this is potentially like the hardest of the hard that they could give you on this exam. But I mean, the more prepared you are for hard questions, the more likely you're gonna solve easy questions correct. But I want you guys to give me your best guess, and then we're gonna go through the question together and talk about what the answer is. Okay, we got one. Do we need to only focus on opioid withdrawal symptoms, or are there other drugs they might ask? Well, this question right now, they can also ask about it. I'm not gonna say the answer because you guys are still answering. And then I would recommend going through your lecture on, I believe there is a lecture on like drugs of abuse or something like that. Just see sort of the ones he emphasizes on. Most of the time, it's opioids and the one that we're about to talk about right now are the two most asked for withdrawals, as well as for overdoses. Alcohol withdrawal is also important, but we're not really asked about it much in university. It's for like step exams and things like beyond. Alcohol withdrawal is asked about a lot. Anyways, any last guesses before I show the answer? I'm gonna show the answer. It's benzodiazepam withdrawal. Hiba, you answered right away. Can you tell me why you thought it was benzo withdrawal? We'll go back to the question as well. Oops, I dropped my pencil. Okay. As Hiba is telling us why, let's go through this question. So, oh, Hiba explained everything. Perfect. Mashallah. So yes, my hint that I gave you guys was that she's having panic attacks. Okay. A lot of this question is filled with a bunch of information that's completely irrelevant. The two main things that you need to know in this question: the patient has panic attacks, and she was given naloxone and flumazenil to reverse her sedation. Okay. Naloxone and flumazenil are used to treat are used to reverse the effects of benzos. All right. So because she was given that, here we have it. Flumazenil, it's a benzodiazepam antagonist, and it can cause benzo withdrawal. The patient is having benzo withdrawal. She has panic attacks, which means that she's probably taking benzos, or let's say for this, she is taking benzos for her panic attacks. And she was given flumazenil to reverse the sedation that she was given for the surgery. But at the same time, he also reversed the sedation of the benzos that she was regularly taking, leading her to have withdrawal, leading to seizures. All right? Did that click for everyone? Okay, perfect. This one is an easier one, even though it's long. So we have a 24-year-old woman or a 25-year-old woman who was brought to the emergency department by her boyfriend because she cut her forearms with a knife. She has had multiple visits to the emergency department in the past few months for self-inflicted wounds. She claims that her boyfriend is the worst person in the world. She and her boyfriend have broken up 20 times in the past 6 months. She says she cuts herself not because she wants to kill herself, but because she feels alone and empty and wants her boyfriend to take care of her. Her boyfriend claims that she's prone to outbursts of physical aggression as well as mood swings. He said that these mood swings last a few hours and vary from states of exuberance and self-confidence to states of self-doubt and melancholy. On examination, the patient is well-dressed and calm. She has normal speech, thought process, and thought content. What is the most likely diagnosis? Okay, gonna challenge you guys a little bit. I want you guys to tell me what you think this is before I show you the MCQs, because this is a very obvious presentation. Like this is a textbook presentation of a certain, yeah, okay, perfect. Yeah, so this is borderline personality disorder. And this question is like the quintessential presentation of borderline personality disorder you're gonna get. If you're gonna be asked about BPT in your exam, this is exactly how you're gonna be asked about BPT. You're gonna have a person, most likely a female patient, who is in her mid-20s, who's self-harming, she's very irrational, and she's breaking up. And this is the picture of borderline personality disorder. It's borderline personality disorder is the personality disorder most associated with self-harm. And here she says again, the self-harm is not because she wants to kill herself, but it's because she wants attention from her boyfriend, which is another key to push you towards saying, okay, this is borderline personality disorder. Is that clear for everyone? Okay, borderline personality disorder is something you're like 99% of you're gonna get asked on your exam. So make sure you know how it looks and how it presents. Here are the signs and symptoms of it from your slide. Like again, you're gonna be aggressive. He said that his girlfriend had aggressive outbursts and mood swings. She said she had self-doubt and emptiness. Concrete thinking is a very important thing in borderline personality disorder. Concrete thinking is sort of thinking, it's a way of thinking where something is either all good or something is bad. There is no in between. You can't be indifferent to something. It's either good or bad. It's sort of black and white thinking. And then usually in a borderline personality disorder question, you're going to have a scenario about a relationship of some sort that's not good. All right. Next question. Okay. A 28-year-old woman came to the physician. By the way, we have a break coming up soon. A 28-year-old woman comes to the physician because of a 1-year history of chronic abdominal pain that developed after starting a job at a law firm. She also has abdominal bloating and constipation that started 2 weeks ago. She has no pain with defecation or change in stool form or appearance. She's upset because she has seen 2 other physicians who have performed tests but were unable to make a diagnosis. The patient is currently on sick leave, but would like to return to work as soon as possible. She often worries about having a gastric ulcer that may perforate and insists on getting an endoscopy. She doesn't smoke or drink. She reports that she's under significant pressure from her manager. She has a history of childhood asthma. She takes Her vital signs are normal. Her abdomen is slightly tender and mildly distended. Remainder of the exam is normal. Lab references are normal. Fecal occult blood tests and urea breath. Oh my God, I have not been able to. Everything is normal. Everything is normal. What does she have? That was hard to read. That was really. Did you guys get the question? Okay, good. F. Yeah, perfect. So this is somatic symptom disorder. This now you guys understand the difference. She's actually having symptoms. She has abdominal pain and constipation. It's real. She has those. Everything else is normal. She has somatic symptom disorder. I feel like there's no need to explain that question. Like we all know the difference of it. I'm going to move on to the next one. If anyone has any questions, feel free to interrupt me. So we have a 38-year-old woman who's coming to the physician for a 6-week history of sleeping difficulty because she thinks that someone is watching her through her security cameras. Her anxiety started 6 weeks ago when the security camera was installed outside of her house by the police. Ever since, she has felt that she is being monitored by security cameras throughout the city. She avoids going outside whenever possible and refuses to take the subway. Whenever she needs to leave the house, she wears large hats or hooded sweaters so that she cannot be recognized by cameras. As soon as she arrives at her office or home, she feels safer. She was recently promoted to the team manager of a small advertising agency. She takes no medications. Mental examination, she's alert, oriented, and shows a normal range of affect. Urine toxicology screening is negative. Her symptoms are best described as what? It may be schizophrenia. It's possible that this could be schizophrenia, but what is she having? Okay. Yeah. Okay. You guys all got it. Did you guys see this question before? You guys got that really fast. Okay. Yes, this is delusions. So what are delusions? They're basically a false belief fixed in reality. That's the easiest way to understand it. So she believes that she's being prosecuted, she's being watched by cameras, and she believes that this is happening in the real world, and no one else in the world thinks that this is happening. No one is seeing this happen to her. There's no reason for this to be happening to her, but she has convinced herself that this is something that is going to that is happening to her currently, that she is being prosecuted by cameras. So these are delusions based in prosecution or persecution. This word. Okay. She's having a delusion. That's clear for everyone. With that, let's take a 10 minutes. Yeah, like let's take a 10-minute, 15-minute break to go pray, and then I will be let's let's continue. Inshallah, from here on out, it's gonna get a little bit easier because the questions should be shorter. Maybe not that short, but still get shorter. So we have a 16-year-old girl who's coming to the physician because she's worried about gaining weight. She reports that at least twice this week, she eats excessive amounts of food, but she feels ashamed about it and losing control. She feels ashamed about losing control after. She's very active in her high school's tennis team and goes running daily to lose weight. She has a history of cutting her forearms with a metal tab from a soda can. Her last menstrual period was 3 weeks ago. She's 165 centimeters tall and weighs 57 kilograms. Her BMI is 21. Physical exam is showing enlarged firm parotid glands bilaterally, and there is erosions at the enamel on the lingual surfaces of the teeth. What's the most likely diagnosis? Okay, everybody already answered. C, C, C. Perfect. Yes, this is bulimia. Eating disorders are important in your exam. They will be asked about. Particularly bulimia nervosa and anorexia nervosa are the two that you're going to be asked most about. So it's important to distinguish between them. One of the main distinguishing features is going to be the BMI of the patient, because a lot of patients with anorexia can actually have binging sessions. People typically think like, oh, people with anorexia don't binge, but they can binge. One of the distinguishing features is going to be the BMI of the patient. If the BMI of the patient is low, that's when you're going to think anorexia. Here we have a BMI that's normal plus binging, so now we're thinking bulimia. On top of that, people with bulimia tend to force themselves to vomit by sticking their fingers down their throat. So some of the signs you're going to see is like erosions or like sort of calluses. I don't know the correct word. The sign on their knuckles from gagging themselves, as well as enlarged parotid glands back, and erosions on the enamel from the vomit coming out and the acidity sort of destroying the enamel on the teeth. So that's going to make you think of bulimia rather than anorexia. Here we go. A short question. Schizophrenia is considered a disease targeting what? Now, this question is confusing, but the reason I brought it is because it came in our exam. And I remember we had a lot of problems with it, or we had a lot of trouble with it. So this is why I wanted to bring it for you guys. Yeah, okay. Any more answers? It could be any of these. I think that's probably what a lot of you are thinking is, oh, it could be any of these. But this is verbatim how our question was asked in the exam, and these were our options. So there is a correct answer. I'll take one more answer before moving on. I saw that it's B, but it's not too good. Okay, so the answer is B. Why is it B? Honestly, it's difficult to say, but we confirmed that it was B. The reason I understood that it's B is that schizophrenia, like a lot of patients with schizophrenia, the main thing that's affected is their thinking. They have memory, it's not messing up their memory, they have cognition as people with schizophrenia are able to, perform day-to-day tasks, granted when they're not having hallucinations or delusions. But really the main thing that is being affected, or the main thing that's being targeted by the disease, is the patient's ability to think. um, is this thing that I'm seeing, is this hallucination that I'm having, is this delusion that I'm having real or not? So this is one of those things where you kind of should just memorize it in case it gets asked to you guys, that schizophrenia is a disease targeting thinking more than any of these other things here. Okay. Perfect. Moving on to the next question. A woman just gave birth and she started feeling slight depressive symptoms within the first week of her delivery with no effect on her social activity. Which of the following is the correct diagnosis? Okay. I'm assuming this was a TBL question for you guys because you got it really fast, or mashallah, you all know it. This is postpartum blues. Important for you guys to be able to differentiate postpartum blues, postpartum depression, postpartum psychosis, okay? Because it's free range for them to ask you any of these things, but you want to be able to distinguish the three of them together. Postpartum psychosis is going to be easy to distinguish as there's going to be risk of the mother either harming herself or harming her child. Postpartum blues is something that is extremely normal to happen. It is going to happen typically within like the first week, 2 weeks of the baby being born, where the mom is just slightly depressed because there's a very, very big change of in her life, which is the baby being born. Postpartum depression is going to be more of those typical depressive symptoms, but it's going to be triggered by the onset of the, I think I have a slide here. Yeah, it's going to be triggered by the birth itself, and it's going to last longer. Okay. So depression is going to begin within the first month of having the kid, and it's going to last for, or it's going to happen within the first 12 months, but it's not going to last longer. So that question that we had previously of the mom who had a 4-year-old boy and depressive symptoms, that can't be postpartum depression because it's lasted longer than 12 months than her kid. Postpartum blues is going to go away around the 2-ish week mark, and it's going to be a lot more milder symptoms of depression. Does that make sense? Do we get it? So make sure you know how to distinguish that timeline because they can ask you any of this. I recall in our exam, we had a couple of questions about postpartum depression and postpartum blues and distinguishing between them. So make sure that you're set in on how to know which one is which. Okay, our next question. So we have a patient that's suffering from anorexia nervosa and has started treatment. And while undergoing treatment, the resident treating her infused her with too many nutrients too quickly in an attempt to speed up her recovery. What is the dangerous complication of this? Okay, I feel like you guys have seen these questions before. Yes, it's good though. It's good that we're repeating these questions because this is the style of questions you're gonna get in your exam. These are electrolytes imbalance. So what we have here is something called refeeding syndrome, which typically happens in anorexic patients or severely malnourished patients. While you're kind of giving them nutrients and nutrition to help recover them, if you give too much at once, the patient is going to go into a severe electrolyte imbalance, which is going to lead to arrhythmias in the hearts and seizures and potentially death. So that is the complication of this, is an electrolyte imbalance. We all understand this? Perfect. Which of the following correctly defines the features of bipolar disorder 2? Great. Another easy one, but again, something that was asked in exams previously is hypomania and depression. So make sure that you know how to differentiate between bipolar 1 and bipolar 2, right? Of the manic features and hypomania. So bipolar 1 is going to have the full-blown mania, which is like the starting a bunch of projects and not finishing them, not sleeping, etc. Bipolar 2 is going to have more features of hypomania, which is just sort of mania, but to a lesser extent. All right. Next question. What is the length of a brief psychotic episode? A recall question that will probably be asked. Okay, looking for more answers. Working on time. Anyone else? Okay. All right. So the answer is actually A. A brief psychotic disorder is going to be less than 1 month. Here's the screenshot from your slides about it. So a brief psychotic disorder, you're gonna have sort of hallucinations, you're gonna have delusions, you're gonna think, okay, this is might be schizophrenia. But remember, you cannot diagnose schizophrenia in 1 month or 3 months. You need a lot, like at least I believe 6 months of symptoms for you to say this is schizophrenia. So you should know that a brief psychotic disorder is something that is less than 1 month. All right. Um, and then there's also talked about delusional disorder and dementia. Dementia can happen and overlap with delusions, but dementia is more of like memory loss, and whilst delusions are more of seeing things or thinking things that are not there. And people with delusions as well usually are acting normally. So if you think about that question that we had previously about the woman who was having persecutory delusions, there was a part in that question that said that she's got a promotion at her job and she's still working normally. So people with delusions are able to function normally for the most part. They just have these delusions as well. All right. Next, what are the most common hallucinations in patients with schizophrenia? Perfect. Auditory hallucinations. I know these are a lot easier, but these are the types of questions that you are more likely to get in your exam, and it's kind of a shame if you miss out on them. So that's why I wanted to bring them so that you know this is the most common of this, is the most common of this, because they're kind of free points in an exam that's 100 and something questions long. So yes, the most common hallucinations in schizophrenia are going to be auditory hallucinations, or yeah, auditory hallucinations. They're going to hear things that are not present there. Again, auditory hallucinations are present in a lot of things, but to know and know it's schizophrenia, remember that you're going to have those hallucinations and you're going to have a long history of sort of this happening as well. We're just breezing through these questions. All right. What is the most common fear in social anxiety disorder? Okay. Okay. Good job, guys. Fear of negative evaluation. Another recall question, another free point for you in the exam, something that is probably going to be asked similarly. People with social anxiety disorder, they're not anxious more so of like going out, they're not scared of being in public spaces, etc. They're scared of being perceived um, negatively, which is fear of negative evaluation. Um, and this is, I remember in our year, heavily emphasized to be an exam question, and I believe it did come as an exam question. So it's important that you guys understand that social anxiety, the root of it is afraid of being negatively evaluated. Okay, a long question to get you guys back on your toes. We had a little break there. So we have a 21-year-old man who's coming to the physician because of nervousness and difficulty sleeping for the past 2 weeks. 3 months ago, he started a new team project at his job. He says that he has trouble falling asleep at night because he thinks about the project. He insists on checking the work of his teammates and spends several hours each week making elaborate lists and schedules. He refuses to let others take on more tasks because he thinks that only he can complete them satisfactorily. The project deadline has already been postponed once, and he tells you, my teammates never understand how important it is to do things the right way. Ever since high school, he has used the majority of his time to, yes, Shahad, that sounds like it. He has used the majority of his time to plan out assignments, and he does not have time to regularly participate in social activities. What is the most likely diagnosis? Yes. Perfect. So obsessive compulsive personality disorder. You guys got it. This is another very important distinguishing thing that you guys need to be able to sort of lock in and know that you know the difference between them, which is OCD and OCPD. So keywords here, OCPD are going to be ego syntonic, which kind of means they like these thoughts that they have. They believe like aiming for perfectionism is a good, they don't think that they're doing something wrong. People with OCD or ego dystonic, which means that they don't like the thoughts that they have. And OCD is going to be more of those repetitive actions, such as washing their hands a bunch of times or opening and closing the door, locking the door, stuff like that. So here's another free MCQ for you guys. They may ask you, what is a key feature of OCPD? And the options will be like ego syntonic, ego dystonic, etc. You're going to go for ego syntonic. While OCD is going to be ego dystonic. All right. So make sure you know how to differentiate between those. That's all I have to say about OCD, OCPD. Are we good with that? Yeah, in regards to these two diagnoses, by the way, the question I just gave you is kind of the the furthest extent they'll give you about these two things, whether it's OCD or OCPD. A lot of the questions are going to be less about saying, okay, what's the diagnosis of it, and more about, are you able to differentiate between OCD and OCPD? Anyways, moving on to the next question. I'm about to show the answer, I think. No, I clicked by accident. A 45-year-old male surgeon is highly functioning at work. His family and his coworkers complain that he's arrogant and always talks about how great he is. There have been complaints about him exploiting others for his own selfish needs and being envious of others' success. The surgeon complained to the doctor that he is too important to have waited in the waiting room for as long as he did. This surgeon most likely has... Yes. Are you guys saying A because you know, or are you saying A because I showed the answer? I'm hoping it's the first. Okay, good. Yes, so this is narcissistic personality disorder. Now there is a lecture about personality disorders that you guys took in psychiatry, where they talked about narcissistic personality disorder, histrionic personality disorder, stuff like that. To be honest, from my experience, you're not going to be asked much about those personality disorders besides narcissistic personality disorder, as it kind of has its own unique presentation, and it's important to diagnose. So basically, this question is just a narcissist. You have to be able to recognize that this is a narcissistic person. All right. Histrionic personality disorder is more of like, the way I kind of understood it back in my year was like main character syndrome, where people with histrionic personality disorder believe that they're sort of like a main character, and so they have these like grandiose, feelings about themselves of like, oh, I'm better than everyone else, and but I'm also a victim and everything, and like it's very sort of dramatic, right? That's histrionic personality disorder. Narcissists are going to use people for their own selfish benefit. So this is narcissistic personality disorder. And here's the DSM criteria. It's not necessary for you guys to understand it, but just some key things that you want to look for in a question with narcissism. They're very self-important. They fantasize about being better than everyone. They need to be admired by people. They have no empathy for others. So here, like, he left the patient waiting, etc. All right, next question. We have a 23-year-old man who's coming to the emergency department with palpitations, sweating, and shortness of breath that began 10 minutes ago. He said, "Please help me. I don't want to die." He has experienced several similar episodes over the past 2 months, which occurred without warning in situations including open spaces and crowds, and resolved gradually after 10 to 20 minutes. He has been staying home as much as possible out of fear of triggering another episode. He has no history of serious illness and takes no medication. He drinks 2 bottles of beer daily. He appears anxious and has a flushed face. His pulse is 104, his respirations are 20, and his blood pressure is 135/82. Cardiopulmonary examination shows no abnormalities, and ECG shows sinus tachycardia. What is the most appropriate initial action by the physician? So first, before you answer the question, what is he having? Someone already said it. Yes, he's having a panic attack. So how do we treat an acute panic attack? Perfect, you guys got it. You're gonna give the patient oral alprazolam or a benzodiazepam to help calm down the panic attack. But I want to go back to this question and give you guys a sort of edited version of it and change the way we're thinking of it. If I gave you this question, but I didn't tell you that his vitals were normal, and I didn't tell you that his ECG was normal, and I didn't tell you that his cardiopulmonary exam was normal. All right. So now you just have a patient coming in with the symptoms above, but we don't know if everything else is normal. If that was the case, what would be your next step? Did you guys understand what I'm asking? Exactly. Then you want to check organic diseases first. So I wouldn't say cardiac stress, I would do an ECG first, but like if these were the options and they didn't give you that, then I would go with A. Even though he's 23, yes. It's unlikely for it to happen, Shahad, like I agree. It's unlikely for a young person to have an MI, but in psychiatry, always, 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 you want to rule out organic causes before you start thinking about psychiatric causes. So in this question, it kind of sounds like an MI. It sounds like a heart issue, but they told you everything is normal. So now you're thinking, okay, this is a panic attack. If they didn't tell you everything is normal, the very first thing you have to do is rule out that it's not an MI before you start thinking panic attack. All right. That's a question that is likely to be asked, by the way. They might ask you of like, what's your next step? And usually it's going to be to rule out organic causes if it hasn't already been ruled out. All right. So just a little slide for you guys. What drugs are used for when? So propranolol, a beta blocker, is used for social anxiety. Busiprone is used for a long-term treatment of anxiety for people who have very severe sort of long-term anxiety. Thiamine, the reason I put this here is because you want to give thiamine first, B1, for treatment of Wernicke encephalopathy. This is less to do with psych, to be honest, and more just like a general neuro tip for you guys. If you're given a patient with Wernicke's encephalopathy and you're asked, what's the first thing you're going to give? Thiamine first. Before anything else, you have to give vitamin B1. And then alprazolam, again, like we just did, it's a benzodiazepine that's used in panic attacks. All right. So this is just a general little slide of treatments. Next question. So a woman was out at a bar drinking when suddenly she felt drowsy and she lost consciousness. Upon regaining consciousness, a toxicology report showed that a drug normally used to treat narcolepsy was slipped into her drink. Which of the following drugs was most likely used? This is a bit of a trivia question, to be honest, more than it is a thinking question. But when going through your slides, I found this drug and it was talked about a bit. So I thought it's possible it could be asked as an MCQ, which is why I brought it. Okay. So the answer is D. I didn't put the slide in, but just know that Xyrem is notoriously known as a date rape drug. So typically the scenario is going to be exactly like this. If you're asked about this in your exam, you're going to have a lady usually out drinking somewhere and then losing consciousness and sort of losing memory of what happened. And it is most likely to be due to Xyrem, which is like this drug used to treat narcolepsy that is slipped into drinks, mixed in, doesn't have a taste, doesn't have anything, and works immediately almost. All right. So this was in your slides as I think in the drugs lecture or like the substance of abuse lecture. Just know that Xyrem is the date rape drug. If you're given a scenario similar to this, it's most likely to be Xyrem. It's sort of trivia more than it is studying, to be honest. Moving on to our next question. We have a 35-year-old lady who developed depressive symptoms after hearing that she's suffering from cancer. The symptoms lasted only a few days and subsided gradually over the next week. She most likely has a normal reaction. Good. This is a question I wanted to bring. Although it is a bit easy, the reason I wanted to bring it again is because when studying psych, at least for me, I would jump at diagnosing a psychiatric disorder before I would think about like normal human emotions and normal reactions. But a lot of the time in psychiatry, the stuff that's happening or the way that you're responding to a situation is normal. So here we have, the horrible news that she has cancer, and she was depressed for a bit, but she got out of it. It's a normal reaction to the bad news. Some people might feel inclined to say depression secondary to the cancer, but again, we don't have the symptoms of depression for us to be able to say that. Depression secondary to cancer is a thing, but it's a different thing. You know what I mean? All right. Anyways, next question. So we have I think this is the second to last question. We have a 20-year-old university patient who is presenting with symptoms which lasted for 2 months and got worse in the last 2 weeks. She's starting many projects, but she doesn't finish them, and she gets distracted very easily, which has affected her grades. She sleeps less, but she doesn't feel tired. She's impulsively buying unnecessary things online, and her friends say that she's unpredictable and gets too excited or too angry over little things. What is your management for this patient? Or like before that, tell me, what does she have? Or what is she likely to be diagnosed with? Exactly, bipolar. One or two, we can't say for sure. It looks like one, to be honest, based off of the question, because the mania is like it's mania, not hypomania. That's yes, you want to do a young mania rating scale and rule out bipolar disorder in this patient, because she is having symptoms of mania. And also, you may be thinking like, okay, where are the signs of depression? And a lot of the times, patients with bipolar are not going to present with signs of depression. They're going to present with the signs of mania. And it's through taking history and sort of talking to the patient more when you're going to say, oh, okay, they actually do have patterns of going into depression and then going into mania. But they're not typically going to come to you with the depressive symptoms rather than they're going to come to you with the manic symptoms. Did that make sense? The sentence wasn't correct. Anyways, next question. 27-year-old woman has been feeling the blues for the past 2 weeks. She has little energy and she has trouble concentrating. She states that 6 weeks ago, she has been feeling very good. She had been feeling very good with lots of energy and no need for sleep. She says that this pattern has been occurring for the past 3 years, though the episodes have never been so severe that she couldn't work. Which of the following is the most likely diagnosis? Perfect. Yeah. Cyclothymia. So this is the reason I brought this is just because I want you guys to know the definition of cyclothymia, as it can be thrown in the options a lot. And a lot of the time when you see a word that you don't recognize as one of the answers and you're not really sure what's going on, you might go and choose that when it's not really the answer. So I want you guys to understand that cyclothymia is a persistent, low mood depression that persists for at least 2 years. So here in this patient, she's had it for 3 years, but she says that it goes away sometimes and they're not so severe that she can't work. Like she's living her life, she just has low mood. All right. So recognize that as cyclothymia rather than, like, for example, recurrent major depression, because it's not really affecting her that much, but she still has that persistent low mood. All right. Now, this is the last question. This is more for fun than anything else. It's a question that I personally did and I found to be very interesting. So I'm going to read it and we'll go through it together. So we have a 5-year-old boy who's being brought to the emergency department by his mother due to a sudden loss of consciousness. He has asthma and has been hospitalized multiple times. His mother has type 2 diabetes and he is somnolent and diaphoretic. Serum study shows a glucose concentration of 22 and a potassium concentration of 2.4. A dextrose infusion is administered, after which his glucose concentration normalized and his symptoms resolve. He's admitted to the hospital for further observation. Overnight, he has another episode of decreased consciousness. Serum studies taken during the episode show a glucose concentration of 19 and an insulin concentration of 108 and a C-peptide concentration of 0.3. So what is the most likely diagnosis? So this feels like a detective question to me, but okay. Okay. Oh, you guys got this really easily. Okay, I struggled a lot with this question. But yes, this is factitious disorder or Munchausen by proxy syndrome. Good job. Wow. MashaAllah, you guys got that really quickly. I struggled a lot with this question. But it's, yeah, the mother is actually injecting the child with insulin, causing him to have low glucose and these sort of hypoglycemic symptoms because she's injecting him with insulin. And the key giveaway here was that he has a high insulin concentration, but a low C peptide concentration, which means it's not natural insulin. Someone is injecting him with it. So this is Munchausen by proxy. It's a case of abuse. A lot of people, or one of the reasons why I struggled with this question a lot is because reading this and looking at these options, it could be any of these things. He could be having an insulinoma. He could be, there could be a tumor. There could be something else going on. But no, this is a case of child abuse with the mother injecting the child and giving him insulin. And thank you. Here is a sort of just a slide from the first aid book of the timeline for diagnosing things that I think it's nice to look at before you go through your exam. A lot of this stuff is going to be not as they're not going to ask too much about timing, to be honest, in your examination, but it helps to know it so that you can organize the thoughts in your head of how to approach a psychiatric exam. To be honest, I would say the most important ones here on the slide is acute stress disorder being less than 1 month, panic being more than 1 month, and post-traumatic stress disorder, again, can also be asked. I think those are important for you guys to know. Adjustment disorder and generalized anxiety are also pretty important. Just know that one is less than 6 months, one is more than 6 months. And then the last thing that I think you should know, I don't know if they are going to talk about it, but it kind of helps to organize things in your head, and you may be able to use it to appeal a question if need be, is the schizophrenia timeline. So a brief psychotic disorder, like we discussed, is going to be less than 1 month. And then between 1 month and 6 months, you can't call it schizophrenia, you call it schizophreniform. Okay, it's not schizophrenia. And then once it's greater than 6 months, that's when you can call it schizophrenia officially. All right. And then just at the bottom, major depressive disorder has to be symptoms more than 2 weeks. Cyclothymia and dysthymia have to be more than 2 years, etc. The ones on top, you don't take in neuro. With that being said, I have concluded my psychiatry practice questions pal. I hope you guys all benefited. Here's my contact information. If you have any questions regarding psych at all or any questions ever, I'm more than happy to answer. And a QR code so that you guys can give me feedback so I can improve for our next sessions. Thank you. You guys did